Here is a number to sit with. The total lifetime cost of care for a person living with dementia is estimated at about $405,000 in 2024 dollars, and about 70% of that burden falls on families through unpaid care and out-of-pocket costs. According to the Alzheimer's Association, Oregon now has about 79,000 people living with Alzheimer's. If you scale that burden down to a county like Jackson, you are talking about a very large human and economic cost carried by families, employers, Medicaid, and the healthcare system. Now, here is the more hopeful number. The CARE, Cutting Alzheimer's Risk Through Endocrinology initiative is a $50 million global research program led by renowned neuroscientist Dr. Lisa Mosconi, funded by the nonprofit organization Welcome Leap. It is aiming to cut women's lifetime Alzheimer's risk in half by 2050. Its public goal is to prevent about 54.5 million cases globally if that prevention model works at scale. That is the difference between reacting to disease and building for prevention. Right now, Southern Oregon is still organized mostly for late detection and downstream care. We are fighting the fire after the house is already burning. This episode is about what we would have to build instead and why it matters now. Welcome to the Reimagine Healthcare podcast. I'm your host, Noah Volz. This is the third and final episode in our series on women's brain health and Alzheimer's disease. In episode 1, we met Carol from Ashland. She was 54, noticing subtle memory changes and getting told her brain was probably fine. In the last episode, we looked at the menopause-brain connection, what estrogen is doing in the brain, and why outdated fear around hormone therapy left a lot of women with incomplete information. Today is the systems episode, the Build It Here episode. Yes, lifestyle matters a lot, but individual effort cannot substitute for a healthcare system that is designed to catch risk early, support women in midlife, and make prevention practical instead of theoretical. So let's talk about what Southern Oregon actually needs to build. When I started researching this series, one of my first instincts was simple. We need more education. If clinicians knew more about menopause and brain health, things would improve. That is true, but it is not enough. The deeper problem is structural. The science now says the key prevention window for many women is midlife, roughly ages 45 to 65. The kind of care that fits that window is not a quick prescription and not a 15-minute visit. It is longitudinal care. It is risk assessment. It is metabolic and sleep support. It is hormone conversations when appropriate. It is early detection before standard office screening would ever catch a problem. That model does not fit neatly inside a system built around short visits, referral bottlenecks, reimbursement codes, and downstream disease management. Think about the mismatch. The research says risk is building quietly over years. The system waits for the impairment to become obvious. The research says women in midlife may need a more personalized conversation about sleep, insulin resistance, blood pressure, menopausal transition, family history, and possibly biomarkers. The system says, do you have 10 or 15 minutes? The research says prevention is cumulative. The system pays most reliably for events, episodes, and decline. So when Carol brings up subtle changes, the science may say, pay attention now. But the system says, come back when it is obvious. That is the gap. And I think Southern Oregon should address it through 5 concrete moves. Ask number 1. The Rogue Valley needs a dedicated Alzheimer's prevention clinic, not a memory care unit after diagnosis. Not a place you enter once dementia is already established. I mean a place a woman like Carol can go in midlife with family history, sleep disruption, metabolic risk, or subtle cognitive change and get a serious workup before the disease is clinically obvious. That workup could include blood based Alzheimer's biomarkers, which are now clinically available through companies like C2N, along with metabolic screening, menopause aware hormonal assessment, and cognitive testing built to catch early changes rather than moderate dementia. Just as important, it would include time. Time to explain what a result means. Time to separate reversible contributors from longer term neurodegenerative risk. Time to build an actual plan instead of tossing out vague advice like sleep better, exercise more, reduce stress, good luck. A clinic like this would not need to solve every problem on day one. It could start as a pilot. One neurologist or prevention focused physician, one nurse practitioner, shared referral criteria, a defined protocol for who gets deeper workup, who gets longitudinal monitoring, and who gets redirected back to primary care with clearer next steps. It could also create something we badly need, which is a center of gravity. Right now, if you are a local clinician who wants to take this seriously, where do you send someone? What testing do you order? Which findings are worth escalation? Which patients need counseling versus imaging versus biomarker discussion versus lifestyle intensive follow up? A prevention clinic would not just evaluate patients, it would standardize the region's thinking. Asante Rogue Regional is the most natural anchor institution for something like this because it already has regional reach and neurology infrastructure. The challenge is not whether Southern Oregon deserves this. The challenge is whether the leadership and funding model are willing to move upstream. And the economics are not trivial. Research modeling suggests that delaying Alzheimer's onset by 5 years could reduce prevalence by about 41% and reduce total societal costs by about 40% by 2050. Prevention is not just compassionate, it is financially rational. That is the part local administrators should hear clearly. A prevention clinic is not just a mission statement, it is a hedge against a very expensive future. Ask number 2. Southern Oregon needs menopause literate primary care at scale. There are bright spots already. Dr. Deborah Gordon in Ashland has long been one of the few local physicians publicly associated with intensive cognitive prevention and precision medicine Alzheimer's work. But one highly informed clinician is not a regional strategy. What we need is ordinary competence across ordinary clinics. That means primary care clinicians who understand that menopause is not just a reproductive transition, it is also a brain event. It means knowing how to discuss hormone therapy timing and formulation in a nuanced way. It means understanding that a woman's Alzheimer's risk profile is not just a copy of a man's. It means taking cognitive symptoms in the late 40s and 50s seriously, even when office screening is still normal. It also means updating reflexes. When a woman says, "I am sleeping badly, my concentration is worse, my word finding is off, my mood is different, and I do not feel like myself," the answer should not automatically collapse into stress, anxiety, or normal aging. Sometimes it will be stress. Sometimes it will be depression. Sometimes it will be sleep apnea or thyroid disease or medication side effects. But that is exactly the point. A better workup is needed, not a faster dismissal. How do we build that competence? Continuing education, regional case conferences, short practical tools for clinicians, referral pathways that do not require a provider to become a national expert before they can help the person in front of them. OHSU outreach, Alzheimer's Association education, and local convening groups could all contribute to that. This could be as practical as a one-page screening guide for midlife cognitive concerns. What to rule out first. When to ask about menopause timing. When to think about sleep apnea. When family history changes the threshold for concern. When to refer. Medicine often improves, not because everyone becomes brilliant, but because the workflow gets better. And to local clinicians listening, I want to say this clearly. You are not the villains here. Most of you were trained in a different evidence era. Most of you are trying to do good work in compressed visits inside a stressed system. But the evidence has moved. And women like Carol deserve care that moves with it. Ask number 3. We need payment reform that rewards prevention instead of waiting for crisis. Here is the absurd version of the current system. A brief visit around symptoms is easy to bill. A long prevention visit that reviews family history, metabolic risk, sleep, menopause timing, biomarker options, and a plan for follow-up is much harder to support. So the reimbursement structure quietly pushes care toward the wrong end of the timeline. And this matters because clinicians respond to incentives even when they care deeply. If a system financially punishes time-intensive prevention, prevention will stay marginal. It will become something offered only by unusually motivated clinicians, boutique practices, or patients who can pay cash. Oregon actually has a real opportunity here because Medicaid is organized through Coordinated Care Organizations, or CCOs, that receive global budgets and have more flexibility than classic fee-for-service medicine. In Southern Oregon, All Care serves Jackson and Josephine counties along with other nearby areas, and Jackson Care Connect also serves Jackson County. That means there are existing regional organizations with some structural ability to invest in prevention if the case is made clearly enough. The ask is not vague. Develop reimbursement pathways for comprehensive brain health prevention visits in midlife women. Pilot them. Measure them. Tie them to downstream cost avoidance. If we can do versions of this for diabetes risk and cardiovascular prevention, we can do it for brain health too. That could mean bundled prevention visits. It could mean special care coordination pathways. It could mean a demonstration project inside a CCO. The point is not that there is only one policy mechanism. The point is that the current mechanism is wrong for the clinical task. And if you are on the payer side, I would frame it this way. The question is not, can we afford prevention visits? The question is, can we afford not to build them as dementia prevalence rises and family caregiving strain gets worse? Ask number 4. Southern Oregon should actively track the CARE initiative and get ready to implement its findings instead of waiting years after the evidence lands. CARE stands for Cutting Alzheimer's Risk through Endocrinology. It is a 3-year, $50 million Welcome Leap program led by Dr. Lisa Mosconi. Its goal is ambitious: cut women's lifetime Alzheimer's risk in half, with the modeled potential to prevent about 54.5 million cases globally by 2050. That matters because CARE is centered on the exact questions this region has been late to face. Which women are at highest risk in midlife? Which biomarkers matter most? Which hormonal or neuroendocrine interventions actually reduce risk? How do we build female-specific risk models instead of treating women as a statistical adjustment inside male-centered data? This is not just abstract research prestige. If CARE helps clarify who benefits from which interventions, when the critical timing window is, and which screening tools actually scale, that will shape clinical practice. The regions that are paying attention early will adapt faster. The regions that are not will spend years pretending the evidence is still uncertain when it is mostly an implementation problem. Southern Oregon women are not going to drive that research from Medford alone. But local systems can prepare now so we do not repeat the same lag that happened after the Women's Health Initiative. We cannot afford another decade or two of delayed translation. Ask number 5. Build a Southern Oregon Brain Health Coalition. Because none of the first 4 asks happen by themselves. Healthcare systems respond to organized pressure. Insurers respond to data and incentives. Legislators respond to constituents who are specific and persistent. And the raw materials are already here. The Alzheimer's Association has support infrastructure in Oregon and presence in Jackson County. Reimagine Healthcare is already creating a local conversation around structural reform. Asante has community benefit obligations. AARP Oregon has advocacy muscle. Local clinicians and women's health advocates already care about this. What is missing is coordination. A real coalition could say, here is the evidence, here is what Southern Oregon is missing, here are the asks for Asante, for regional payers, for the Oregon Health Authority, and for local elected leaders. It could host public education nights. It could create a regional policy brief. It could ask local employers to pay attention to caregiving burden and women's midlife health. It could give reporters, patients, clinicians, and policymakers a shared frame instead of scattering the issue across disconnected conversations. And coalitions matter because they change what feels normal. 1 patient sounds like an anecdote. 50 patients, 10 clinicians, a nonprofit, and a policy brief start to sound like a regional issue. That is when institutions stop nodding politely and start assigning meetings, budgets, and timelines. That is buildable right now. And if you listened to episode 1 and recognized Carol, or recognized yourself in her, that is exactly why this should matter. I said this episode would focus on systems, and it has, but I also do not want to leave you without the part that is in your hands right now. The Lancet Commission has estimated that about 45% of dementia cases worldwide may be attributable to modifiable risk factors. That does not mean prevention is simple. It means there is real room to act. A few things matter enough to name directly. First, sleep. Deep sleep helps the brain clear metabolic waste, including amyloid-related proteins. Chronic sleep disruption is not just exhausting. Over time, it may raise dementia risk. For many women in perimenopause, that means night sweats, fragmented sleep, and 3 a.m. wake-ups are not just quality of life issues, they are brain health issues. Second, metabolic health. Insulin resistance, obesity, hypertension, and physical inactivity are all part of the dementia risk picture. If your blood sugar regulation is deteriorating in midlife, that is not separate from brain health. It is part of the same story. Third, exercise. The evidence is strong here. Regular movement supports insulin sensitivity, vascular health, neuroplasticity, and overall brain resilience. You do not need a heroic routine. You need consistency. Fourth, hearing, depression, and social isolation also matter. One of the useful things about the prevention literature is that it stops pretending the brain is separate from the rest of life. Sensory decline, loneliness, poor cardiovascular health, inactivity, and sleep disruption all stack together. Consistency beats intensity. A 3-week burst is not the goal. The goal is protecting the brain over years. So if you are listening and wondering where to start where friction is lowest. Improve sleep, walk most days, lift something a few times a week, get your blood pressure under control. Take hearing changes seriously. Build habits that can still exist 6 months from now. I want to close with something honest. If you had asked a lot of careful people in medicine a few years ago how hopeful they felt about Alzheimer's, you would have heard a lot of quiet pessimism. Too many failed trials, too much late-stage disease, too few tools that mattered early enough. I think that frame is changing. We now have better biomarker tools. We have stronger imaging work around women's midlife brain changes. We have more serious attention to sex-specific risk. We have major research programs like CARE, and we have a much clearer sense that the long preclinical phase of Alzheimer's is not just a period of helpless waiting, it is a prevention window. That matters psychologically as much as clinically. If a disease is only visible at the end, people feel doomed. If a disease has a long detectable runway, earlier leverage points, and multiple modifiable contributors, the emotional posture changes, not to false certainty, but to strategic action. That does not mean victory. It means opportunity. The goal is not to cure every case tomorrow. The goal is to help fewer people get there in the first place, or to push the clinical onset far enough out that families get more healthy years and science has more time to catch up. That is what reimagining healthcare looks like here. Not waiting until Carol is 74 and clearly impaired. Catching her when she is 54, still functional, still resilient, still in the window where action matters most. If you're a woman in perimenopause or postmenopause, ask your clinician direct questions about sleep, metabolic health, family history, cognitive change, and whether menopause is part of the brain health conversation. If a provider brushes that off too quickly, that is information. It tells you something about how current their frame is. If you are a primary care clinician in Southern Oregon, update your frame. The women in your waiting room with subtle midlife cognitive changes deserve more than reassurance by reflex. Even if you cannot solve the whole problem in one visit, you can ask better questions and create better follow-up. If you are an administrator, payer, board member, or policymaker, the ask is even simpler. Run the numbers on prevention. Build the pilot. Fund the longer visit. Create the regional referral pathway. And if you are a community member who wants to stay close to this work, subscribe at reimagine-healthcare.org. That is where we will share future reporting, local events, and practical next steps as this conversation turns into something more organized. The benefit of subscribing is simple. You will know when this turns from analysis into local action. Share this series with one woman in midlife, one primary care clinician, or one local decision maker. That is how this moves from an interesting podcast to regional pressure. And that is really the practical test for this whole series. If it only leaves you informed, it did part of its job. If it changes one conversation in a clinic room, one referral decision, one payer meeting, or one family discussion, it did much more. We started this series with Carol from Ashland, trying to decide whether to trust her own experience or the reassurance she was given. I want to end with a different version of Carol's story. Carol brings up her symptoms, and her clinician does not dismiss them. She gets a more serious evaluation. Her sleep gets addressed. Her metabolic risk gets taken seriously. Her hormone conversation is informed by current evidence. If needed, she gets referred into a regional prevention clinic instead of being told to wait until something is obviously wrong. She has a follow-up plan instead of vague reassurance. She understands what is known, what is not known, and what she can actually do next. Her family is not left guessing whether this is nothing or the beginning of something important. She goes home feeling informed, not brushed aside. That version of care already exists in some places. It is not science fiction. It is an organizational choice. The real question is whether Southern Oregon is willing to build it here. This podcast is for educational purposes only and is not medical advice. I work hard to get the details right, but science moves fast, and I am not infallible. If you catch an error or want to share perspective or lived experience, reach out through reimagine-healthcare.org